Okay, sir.
Okay, so we are starting this class after a long time, nearly 1.5 years. So we'll start with today's class, which is seizures and epilepsy. Dr. Aravind will be presenting, and I'll be moderating in between. So there'll be lots of chats and discussion in between. It won't be like a routine talk, so that we can understand more. So we'll start with Dr. Aravind. Proceed.
Good afternoon, everyone. We'll straight away go with the topic seizures and epilepsy. To begin with, a definition: a seizure from the Latin word
More
sacre,
louder. Not audible.
uh, to take possession of, is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. It is estimated that approximately 5 to 10% of the population will have at least one seizure, with the highest instance occurring in early adulthood and late adulthood, early childhood and late adulthood. Coming to epilepsy, epilepsy it describes a condition in which a person has risk of recurrent seizures due to a chronic underlying process. Seizures due to correctable or avoidable circumstances does not necessarily have epilepsy. Single seizure associated with clinical or electroencephalographic features pretending high risk of recurrence may establish the diagnosis of epilepsy. The incidence of epilepsy varies between 0.3 to 0.5% in different populations. International League Against Epilepsy defines epilepsy syndrome as a characteristic cluster of clinical and EEG features, often supported by specific etiological findings, can be structural, genetic, metabolic, immune, and infectious. The prognosis, the comorbidities, the etiologies can vary. Based on the clinical features and the EEG features, International League Against Epilepsy in 2022 came with a classification. They divided syndromes based on either age of onset or the type of onset. It can be generalized onset seizure or focal onset seizure, or generalized and focal onset seizure, or it can be associated with development. It can be developmental and epileptic encephalopathies or progressive neurological deterioration. Based on the age of onset, neonates and infants can begin with childhood, or it can have a variable presentation or sometimes idiopathic. This is the classification they have proposed in International League Against Epilepsy. There are different types of epilepsy which they have mentioned here. I just want to briefly mention about the types. Epilepsy syndromes with onset in neonates and infants, namely self-limited familial neonatal epilepsy, self-limited or familial infantile epilepsy, self-limited familial neonatal infantile epilepsy, which are all focal seizures. Generalized epilepsy with the febrile seizure plus, it can be focal and or generalized. And then we have generalized epilepsy, there is myoclonic epilepsy in infancy. Similarly, epilepsy syndromes with onset in childhood, which are self-limiting epilepsy with centrotemporal spikes, self-limiting epilepsy with autonomic seizures, childhood occipital visual epilepsy, photosensitive occipital lobe epilepsy, generalized seizures with the onset in childhood, epilepsy with the myoclonic absences, epilepsy with the eyelid myoclonia, epilepsy syndromes with the onset at a variable age, mesial temporal lobe epilepsy with hippocampal sclerosis, familial mesial temporal lobe epilepsy, and sleep-related hypermotor hyperkinetic epilepsy, familial focal epilepsy with variable foci, epilepsy with auditory features, and then we have epilepsy with reading-induced seizures, idiopathic generalized epilepsy. We have childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures. Coming to focal onset seizures, it arises from a neuronal network, either discretely localized within one brain region or more broadly distributed, but still within cerebral hemisphere. can arise from the medial temporal lobe or inferior frontal lobe. These regions can be distant from the scalp recording, which may be non-localizing. The region of seizure onset may be detected using surgically placed intracranial electrodes. These focal onset seizures can have motor manifestations, which can be tonic, clonic, or myoclonic movements, or even non-motor manifestations like somatic sensations like paresthesia, visual disturbances like flashing lights or formed hallucinations, hearing, olfaction, or dissociation. I mean, disturbances in the equilibrium like sense of falling or vertigo, or there can be autonomic features like flushing, sweating, or piloerections, or emotional disturbances like fear, or a sense of impending change, detachment, depersonalization, or even deja vu or illusions that objects are going smaller, like micropsia or macropsia symptoms can be there. In addition, Jacksonian march, which represent the spread of seizure activity over a progressively larger area of motor cortex, and Todd's paralysis, a localized paralysis for minutes to many hours in the involved region following a seizure, and epilepsy partialis continua. That is, the seizure may continue for hours or days and is often refractory to medical therapy. Can all be seen in focal seizures. Again, the focal seizure can be classified based on the awareness. Focal seizures with consciousness and with the impaired awareness. What is aura? Aura is subjective internal events that are not directly observable by someone else. It typically begins, it is seen in the beginning of seizures where the consciousness is impaired, and automatisms or involuntary automatic behaviors may consist of very basic behaviors such as chewing, lip smacking, swallowing, or picking movements of the hands, or more elaborate behaviors such as display of an emotion or running. Immediately following the seizure, they may show an anterograde amnesia or transient neurological deficits such as aphasia, hemineglect, or visual loss, which is caused by post-ictal inhibition of the cortical regions. Focal seizure to generalized seizures. We should concentrate more on history, where there may be preceding aura to differentiate, or sometimes may be established only through careful EEG monitoring. Generalized onset seizures,
Dr.
it
Aravind,
arises at some point in the brain.
hello. Okay, can you
Sir.
tell me something about how the focal seizures start? We have something concept called as the zones of epilepsy. Are you aware of that?
No, sir.
Okay, so the concept is focal seizure, as you told, is classified into two types: focal seizure with impaired awareness or focal seizures with intact awareness. The older term for this was simple complex seizures and complex partial seizures. Now these terms are not used. So it's better to use focal seizures with impaired awareness or focal seizures with intact awareness. For any focal seizure, there's something called as zones of epilepsy. So one is called, suppose assume that there's a small lesion, be it a calcified lesion or a small hematoma in a particular part in the temporal lobe. That particular part is called as ictal onset zone because this all seizure activity starts from that zone. Okay, it's called ictal onset zone. Assume multiple circles around that. So the area immediately surrounding that ictal onset zone is called as epileptogenic zone because all the channel changes will occur in that zone. The zone surrounding that is called as the symptomatogenic zone or functional deficit zone. Surrounding that is called irritative zone. So we have four zones: ictal onset, epileptogenic, symptomogenic, and irritative zone. So this concept is very important because the seizure, the ictal onset zone may be in the temporal lobe, but all the symptoms or the epileptic activity starts from the zone surrounding that. So it may go to the parietal lobe or the frontal lobe. Okay, so a patient who has a lesion in temporal lobe can present with symptoms which can be localized to the frontal lobe. So that's something called as semialgia of seizures. So whenever some patient presents, what is more important is the aura which you told. Suppose if the symptomogenic zone is in the occipital region, patient will have symptoms like vision disturbances, flashing of lights. So based on how the symptoms progress, we have to document it. It is called a semialgier seizure. This concept is very useful in places where you consider surgery for epilepsy, surgery for seizures. Because even though we label a patient based on the symptoms as originating from occipital lobe or temporal lobe, the actual lesion may be somewhere else. Okay.
Yes, sir.
And you should know the difference between aura and premonitory symptoms. Aura is a term which is associated with the two diseases. One is migraine, another one is uh, partial seizures or focal onset seizures, where we can localize the symptom to a particular lobe. For example, sensory symptoms like unilateral numbness can occur in parietal lobe as a part of parietal lobe symptoms. Any hearing disturbances can occur as a part of temporal lobe. The visual disturbances which we commonly tell is due to irritation of the occipital lobe. Whereas premonitory symptoms cannot be localized to a particular lobe. Premonitory symptom is a feature of generalized onset seizures, whereas aura is a feature of focal onset seizure. Okay, okay, continue.
Uh, Moving on to types of generalized onset seizure. Absence seizures. These are sudden, brief lapses of consciousness without loss of postural control. Usually, there is no post-ictal confusion. Subtle bilateral motor signs such as rapid blinking of the eyelid or chewing movements or small amplitude clonic movements of the hands can be present. It is associated with a group of genetically determined epilepsies also. The onset is usually in the childhood between 4 to 10 years or sometimes in early adolescence. It is often misdiagnosed as attention deficit disorder and is mostly picked up by teachers in the school. EEG shows a burst of generalized symmetric 3 Hz spike and slow wave discharges that begins and ends suddenly, superimposed on a normal EEG background. Hyperventilation tends to provoke seizures and EEG changes. Atypical cases can deviate both clinically and electrophysiologically and are often refractory to treatment. Uh, Based on the onset, the absence seizures can be either childhood onset or juvenile onset. Many features overlap. Moving on to generalized tonic-clonic seizures, approximately 10% of all persons with epilepsy may have GTCS. This is the most common seizure type resulting from metabolic derailments. Some patients describe vague prodrome, like what we discussed now, that is distinct from the stereotypic aura associated with the focal seizures that generalized. There can be ictal cry, which is due to tonic contraction of the muscles of expiration and the larynx at the onset that will produce a loud moan. Respirations are often impaired, secretions pool in the oropharynx, and cyanosis can develop. Sympathetic tone is also increased. Uh, the characteristics of GTC seizure is that after 10 to 20 seconds, the tonic phase of the seizures typically evolves into the clonic phase, produced by the superimposition of periods of muscle relaxation on the tonic muscle contraction. That is, uh, in between tonic contraction, there will be clonic phase, followed by a post-ictal phase, which is characterized by unresponsiveness, muscular flaccidity, and excessive salivation that can cause stridorous breathing and even partial airway obstruction, and bowel and bladder incontinence may occur.
These
During
phases are
tonic
very
phase,
important. These phases are very important because we have 4 stages: premonitory phase, which was discussed, and we have tonic phase. So before the actual clonic movements occur, there will be some tonic movements where we have something called a ictal cry, posturing, and all. Generally, we have the clonic phase, which we commonly encounter, and post-ictal phase. So most of the time, to differentiate whether syncope or seizure is there, these 4 stages, identifying these 4 stages is necessary. Like bladder and bowel incontinence usually is associated with seizure. It can occur with syncope, but commonly occurs with seizure. Tongue bite occurs during the tonic and clonic phase. So lateral tongue bite can be seen, and excess salivation. So these 4 stages we are able to identify in any event, it can mostly point towards a seizure. Whereas in differential diagnosis of seizures like syncope, we cannot clearly demonstrate all these four phases. So in syncope, they fall down suddenly. It's like an atonia rather than this tonic, clonic, and postictal phase. And but we may not get all these four phases in every case. That's why there's some variants like tonic variant, clonic variant, and all. But usually these four phases can be demonstrated. And how long this postictal phase can last?
Approximately 15 to 20 minutes.
More than 10 minutes. Because if postictal phase less than 10 minutes, it is mostly a syncope. So postictal phase will last more than 10 minutes. Okay, continue.
Like sir mentioned, there are variants like pure tonic seizures or pure clonic seizures. These pure tonic seizures may be associated with epilepsy syndromes. So all these are criteria proposed by International League Against Epilepsy. That is mandatory criteria is generalized tonic-clonic seizures should be there. EEG 3.5 to 5.5, 3.3 to 5.5 hertz generalized spike wave or polyspike wave should be present. An MRI is not required in every case, but should be considered with alerts or if clinical suspicion of possible structural lesion exists. It is not necessary the ictal EEG should be performed for confirming the diagnosis.
So this
So
line is very important. And ictal EEG is not required for the diagnosis. And MRI is not required for every case. Because most of the time, when we are in confusion, we always order an EEG. And once EEG is normal, we have a tendency to tell it's not seizure. It is never so. Seizure is always a clinical diagnosis. In the definition of epilepsy, which was mentioned earlier, ILAE definition, they give the term clinical and EEG features. So clinical stands first. So once you are able to demonstrate that the particular clinical activity is a seizure, that alone is enough for a diagnosis of seizures. You need not have a corroborated EEG for diagnosis. EEG abnormalities can add evidence to a diagnosis, but seizure is primarily a clinical diagnosis. Okay, similarly, a normal MRI cannot rule out seizure. Okay, this is very important. Seizure is primarily or epilepsy is primarily a clinical diagnosis. And EEG, not every change, because when we never see the EEG waves, we always see the EEG report only. They may give some borderline changes or some words they may give. It's not every EEG change is not suggestive of seizures or epilepsy, because you can see in the first row last, there are some exclusionary criteria in EEG, right? Because focal slowing, triphasic pattern, all this can be a part of metabolic encephalopathy and not seizure. You should have 3 to 5.5 hertz generalized spike waveform to describe it as GTC. Okay, so that is the most important point. Don't rely on EEG. Seizure is always a clinical diagnosis. When in doubt, you treat a seizure. But EEG and MRI can help to find out from where the seizure is originating, like in a focal seizure. Similarly, MRI can find out where the ictal onset of zones. That is the role of MRI and ictal. Similarly, what is the first investigation of choice? Structural imaging is CT. MRI may not be possible in most of the time. CT can rule out most of the things. Okay. So I think only one more minute before the 40 minutes time ends. So we'll summarize what all happened till now. So Aravind was discussing about the ILA, International League Against Epilepsy classification of seizures. So seizure is the clinical symptom. It may be due to any reason. Epilepsy has a specific definition, recurrent seizures without any predisposing cause. So based on the cause, we can classify seizures as two. The old term was acute symptomatic seizures, also called as provoked epilepsy. The other one is epilepsy, as you was told. So if you are able to find out any cause, it is labeled as ASS, acute symptomatic seizure or a provoked seizure. If there is no cause, if such episodes occur, then it can be labeled as epilepsy, right? So we were discussing about the classification.